Hi dear colleagues and welcome to this dental case. In this video I would like to talk to you about a case that I also presented on the Karma On Tour conference. This case is a case consisting of two non-prep lateral ceramic veneers that I placed in a young patient. I will take you through the case. I will show you some of the slides that I also showed during my presentation. If you have any questions, feel free to comment down below. And if you like this channel, please like and subscribe the video because it would really help me to grow this channel. Okay, let's get started. The patient came to me on a referral of a friend of hers, and she didn't like the aesthetics of her smile. She had multiple diastemas and she felt like she had a child's smile. As you can see, the teeth all look a little bit short, so the length-width ratio is not correct, and we also see multiple diastemas, not only in the upper jaw but also in the lower jaw. When we take a close-up, we see that the teeth are a bit small, so there's probably a tooth size discrepancy, also called a TSD. That means that the teeth are a bit too small compared to the other teeth in the mouth. And when we look at the lateral incisors, they seem to be a bit small. What I always do when I have patients like this, I always take a photo protocol. I have certain pictures that I take. I will tell you about that protocol in a different video. But I always make a DSD to visualize for myself, but also for the orthodontist or for the lab technician, what I want to achieve in a dental case. Well, what I did in this case, I outlined the teeth and I positioned them in the arch to see where they would fit and where it would leave any diastemas for me. By changing the two central incisors and placing the lateral incisors a bit more inward, we can see that we are left with a small diastema, but when we align it perfectly, we already will be very close. Well, this is something that I sent to the orthodontist and we discussed where we wanted to leave the diastema. Do we want to leave a small diastema on both sides, on the distal sides of the lateral incisors, or do we want to leave them at the distal side of the cuspid? And that all depends on the occlusion, because you want to have a good class 1 occlusion. So if that's possible and we have a TSD, so a tooth size discrepancy, we need to figure out where we want to place the diastema to have and to get a good function. Well, when you take a look at my DSD, you can see that I outlined where I want the teeth to be. And you could also see that the central incisors could be a little bit longer, and that the lateral incisors need a bit more mass. They need to be a bit bigger. When we look at this picture, this was my initial picture and my initial plan. I thought I also needed to do a little bit of gum refinement to get a better length-width ratio. And then when we rotate the laterals and place them more in the arch, we would get a better result and then see what we need to do. We talked about non-prep porcelain veneers, but we also talked about composite restorations. And we decided that we would look at the end of the orthodontic treatment what we would do. Well, I saw the patient maybe a year and a half later. She was treated by an orthodontist with AirSmile, and this is the result when she came in. We did a little bit of bleaching. Also, my photography protocol changed a little bit. I got a different setup. So as you can see, the pictures on this slide are more yellowish and more red, and these are a little bit brighter, a little bit more natural. But what you can see is that the Invisalign already achieved a really great result. The central diastema is gone. The central incisors look longer. And also when we take a look at the position of the lateral incisors, they seem to be in a perfect position. So you can still see the attachments of the Invisalign here on the teeth. But when I saw her again, I asked her if she still wanted to change anything because it already looked pretty damn good. And when you look at this side, we see that we have a small diastema on the distal side of both lateral incisors, but it isn't bothering me at all, to be honest. Well, she had the idea in mind that we would get a better length-width ratio of the teeth, we would get more volume to the lateral incisors, so we talked about the different treatment options. I also made these pictures, this entire photo series, and I sent it to my technician, and we discussed what would be a great option. Should we go for composite? Should we go for non-prep veneers? And in the end, we decided that non-prep veneers would be the nicest, most aesthetic treatment outcome in this case. Here you can see the intraoral picture from the buccal view, and you can also see that the gingiva in the cervical area of the central incisors is way better, and right now it doesn't need any gingival recontouring. This is a photograph of the lab work by my dental technician. This was done by Oral Design Apeldoorn by Eric Mentink. And as you can see, here's the cast with both of the non-prep feldspathic veneers, and you can see that they are really, really thin. They are like an eggshell, as thin as and you can, if you hold them towards the light, you can see through them. Well, it's feldspathic porcelain, and when we are going to bond these, we have a certain bonding protocol. First, I etch them with hydrofluoric acid, 9% for 120 seconds. Then I use a phosphoric acid, 37% for 60 seconds, just to clean the porcelain. Then I use an ultrasonic bath, and after the ultrasonic bath, I use a ceramic primer by Cureray. I use the OptiBond FL bonding, I don't cure it, and I use the Cureray Majesty Flow to cement it. I am usually a big fan of heated composite, but in these cases that will be too thick and not flowable enough to use, and you will probably end up with a crack or some breaking of your veneer. So in these really thin cases, I always go with some flowable. On the day of cementation, we apply a full rubber dam, which means we place a rubber dam from the first premolar to the first premolar, or the second premolar to second premolar, but I want to have at least 8 to 10 teeth isolated. By doing that, I make sure that I have a good overview. I create some room for myself and for the assistant, for the suction, for my handpiece, for my mirror. And by isolating multiple teeth, we will also get a better retraction of the gums. Here you can see a close-up of the full isolation. And when we are going to bond the teeth, I want to get more retraction locally. So what I do, I use an additional clamp. And in this case, I use the B4 Brinker and an Isodam heavy rubber dam. And the B4 Brinker gives me that extra retraction, so I know that I have enough room to place the ceramic restoration. I don't want to end up in a situation where I think I have enough space, and when I'm trying to cement it, I see that it hits my clamp, that it interferes. So it's very important to test it before. So after I do this, after I always do a try-in in the mouth without rubber dam, see how it fits. I use a little bit of water or some glycerin. But in these cases, I always, after isolation and after the additional clamp, I also try the ceramic restoration again to see if it fits and if there aren't any interferences. I use 2 partial matrix bands that we use for posterior restorations to make sure that the adjacent teeth are covered. And then I use the AquaCare with aluminum oxide, 29 micron, to aerobrate the enamel. After aerobration, I apply phosphoric acid for 30 seconds. When we etch enamel, we always do it for 15 seconds. When we do a total etch system, for example with OptiBond FL, and there is some dentin exposure, I would like to do that for 10 to 15 seconds. Then we place the OptiBond FL bonding. Since there is no composite or anything, I don't need to use any ceramic primers. I don't need to use any primer at all because there is no bonding, there's no dentin exposure. I place the OptiBond FL bonding, but I don't light cure it because when I light cure it, I could have a problem with the seating of the restoration. I already told you how to pre-treat the restoration. I apply a little bit of flowable on the inside, and then I gently slide it in its place, and all the excess is removed using some micro brushes, some other brushes, and to make sure that there isn't any excess before I light cure. And that's one of the big benefits of using composite or flowable, is that it only sets when I want it to set, and that's when I put my lamp on it. And if, for example, you use something that is a dual cure cement, you could run into the problem that it's already setting while you are still making sure that the restoration fits. So I'm a huge fan of using a flowable or a composite. After I cemented it, after I light cured it, I will always use a glycerin for the air inhibited layer to make sure that the top layer is also fully polymerized, and then I can start with the polishing of the restoration. You always have to be careful in these kind of situations, and what I do, I use a small IPR strip of 30 microns just to remove the excess of bonding. Usually the only excess is a little bit of bonding or a thin layer of flowable, and you can easily remove it using an IPR strip or any other sanding strip. And what I always do is I use a blade. I really love the Swan Morton 12D scalpel, and that scalpel is has a cutting edge on both sides, which makes it really easy to remove all the remnants of bonding and flowable. And this is what it looks like post-op. As you can see, it's a really nice result without prepping any teeth, without needing to touch a burr. We only did a little bit of Invisalign, a little bit of bleaching, and 2 non-prep veneers. Thank you for watching this video. If you have any questions or comments, please leave them below in the comment section. And if you like this video and like this channel, please like the video and subscribe to my channel because it would really help me. Thank you, and I hope to see you soon. Bye!